In this lecture, Pathophysiology of Infections, we're going to address some overall concepts that are important when we think about infections, but also address some of the characteristics of bacterial, fungal, and viral infections, and provide examples of each. So as you can see, the outcomes, I think it's important first, and this is your responsibility, look at the factors that influence the ability of a pathogenic organism to cause disease. This is in your text, and I think it really helps sort of set the stage as we think about how pathogens are able to cause disease, like communicability, infective, portal of entry, those kinds of things. We'll take a look at the stages of progression, as well as clinical stages of an infection itself. Key characteristics of pathogenic organisms, because they all have some key characteristics that you need to be aware of because it helps you understand them. Then we'll look at some of the common bacterial, fungal, and viral infections and how they invade, avoid destruction, as well as cause tissue damage. We'll differentiate between herpes simplex and herpes zoster. Talk a little bit about how vaccination and immunization prevent communicable disease pathology, and then end with a brief discussion of antibiotic resistance. So let's start by talking about some of those overall concepts. The two big concepts include stages of progression as well as the clinical stages. So when we think about stages of stages of progression, there are four general stages to consider. And of course, we know that we have organisms present, but we don't necessarily become infected by those organisms. But the first stage of progression is colonization. In colonization, the organism actually adheres to surface receptors. And that's an important stage because by becoming colonized, by adhering to surface receptors, it provides a measure of protection from removal by the immune system. During invasion, the organism is actually avoiding the immune system defenses. The organism penetrates the tissue and avoids the responses of both inflammation as well as the immune system. Because remember, both inflammation and the immune system are functioning to try to get rid of or to remove this invading organism. Now, it's important to remember that we don't always, when we have an organism, we don't always move from colonization to invasion. We may actually stop at colonization and don't move to invasion unless the environment is right. But once the organism has invaded, they have penetrated the tissue and are avoiding the immune system and the inflammatory response, now they undergo multiplication. I call this the bunny phase, because this is a phase in which there is rapid cell growth and cell division and multiplication, and this is where the organism actually gets hold of the organism. It has increased copies, and it makes a lot of copies before the immune system responds. Remember that it can take 3, 4, even 5 days for the immune system to mount a good response or a very solid response to the antigen. So it's to the infectious organism's advantage to be able to multiply rapidly so that it has enough copies out there so that it can start to resist the immune system removal. And then last but not least is the idea of spreading of this organism. And this can be local, or it can be disseminated. So when we say local, it may be within a defined area, or as we know with sepsis, it may be disseminated throughout the system. And the spread of an organism varies quite a bit, because in order to disseminate, it's going to rely on adhesion molecules, it's going to rely on the ability to produce toxins, and the ability to protect itself from being removed by the body. When we see an infection occur, we usually see this within fairly well-defined clinical stages, and that tells us what's going on in the pathology as well. So during the incubation stage, we're talking about an exposure to the pathogen until the organism develops or demonstrates symptoms. So during that incubation phase, we know that there's a lot of multiplication. This is where the bunny phase is very important. In the prodromal phase or stage, we start seeing the initial symptoms. And these are usually very broad, very vague. And we've all had these, the fever, feeling tired, feeling achy. So as a result, these prodromal symptoms, because they are broad and nonspecific, they aren't terribly specific to the organism that's actually causing the disorder or the infection. During the invasion stage, however, specific symptoms that are related to the organism and the inflammatory response begin to occur. So a great example of that, and we'll be talking about measles a little bit, is when you look at rubella versus rubeola. Both of these have a fairly, they have different incubation periods. They have similar prodromal symptoms or prodromal stage symptoms. But when it begins to invade, the rash that you see with rubella is very different from the rash that you'll see with rubeola. And then we have the convalescent stage. During the convalescent stage, there are fewer symptoms and the organism, the body, begins to recover. And we can actually go to full recovery or the infection become latent. When infection becomes latent, it quiets down, and what it's really doing is there are fewer symptoms and it's waiting for reactivation. It's waiting for the right environment in order to begin growing again. We talked about that idea of reactivation or really waiting for the right environment when we talked about cancer cells. So if we think about all of the stages, though, all of the stages depend on two big things. One is it presumes transmission. So this could be direct contact. It could be through a vector like a mosquito. It could be direct contact with a contaminated material. I went to a great lecture, it's been about a year ago now, and it was with an infectious disease specialist, and he said the most dangerous organism in our world today is the mosquito. And a lot of that is because a mosquito is a very common vector for transmission. The second thing that they depend on is a receptive environment. So in order for something to become colonized, it either has to create environment for itself or it has to actually change the environment. So the environment itself has to be receptive to be colonized, or the organism has to change that environment to be receptive. So let's turn our attention to infections themselves. We're going to talk about three types of infections. We're going to talk about bacterial infections, fungal infections, and viral infections. Now you will see protozoan and helminth infections in your practice, but we're going to cover the big three, and I won't hold you responsible for the others, although many of the concepts that we talk about are still good. Again, I don't expect you to memorize, but it's important that you know the characteristics of bacterial infections versus fungal infections versus viral infections. So as we start thinking about this then, one of the first things we want to remember about is our basic microbiology that we all took in our undergraduate program about a bacterium. Bacteria are unicellular organisms that do not have a nucleus and do not have mitochondria. So if they don't have mitochondria, they can't make, oh, I heard you shout, yes, ATP. So bacteria are unable to make ATP, and that means they have to have a steady supply of nutrients. Now, despite this inability to make ATP, as we well know, bacteria do just fine. The second thing that is important is we want to remember that bacteria come in a variety of groups, and in general there are two big groups of bacteria. They are either gram-negative or they are gram-positive, and this is based on the different kind of shell the bacteria has. And it's based on a purple stain, the gram stain, that they either take up or they don't take up. So let's talk first about gram-negative organisms. A gram-negative organism does not take up the purple stain, therefore it doesn't stain, it's gram-negative. What these organisms have is a lipopolysaccharide shell, so they've got like an extra coat, and that's what prevents them from taking up the stain. In addition, this polysaccharide coat is actually an endotoxin. Two very common organisms that you have probably have a fair amount of knowledge about is E. coli and the H. flu bacterium that is implicated in community-acquired pneumonia. E. coli heavily implicated in urinary tract infection. But H. flu, that bacteria, is implicated in community-acquired pneumonia, especially in elders over the age of 65. And yes, for me at least, elder is getting older than that. The second type of bacteria is a gram-positive bacteria. These do take up that purple stain, that gram stain, therefore gram-positive. And there are probably more gram-positive than there are gram-negative, so this is a very, very large family. Examples of gram-positive organisms include Streptococcus, Staphylococcus, both Staph aureus and epidermidis, and Clostridium difficile. And that we know that we have a lot of problems in healthcare today, whether you work in the community or within a healthcare delivery system, an acute care environment, with that large family of bacteria. So we know something about them. We know something about the bacteria. We know something about their grouping, whether they are gram-negative or they are gram-positive. So another thing we want to remember, and is very important about the pathophysiology of a bacterial infection, is it has to be able to adhere. And bacteria adhere through pili. And the specific pili, which are projections from the bacterial surface, may actually vary within the strain of bacteria. But the pili are important in order to bind, and they have to be able to bind to cell membrane protein receptors. That allows them to bind to the tissues, and indeed, as part of that binding, may actually inactivate cells of the immune system. So some of the common receptors include the fibronectin, the hemagglutinins, erythrocyte surface molecules, collagen, and polysaccharides. Another important characteristic in the pathophysiology is they have to be able to survive. Bacteria are very, very tricky little devils, and they have multiple mechanisms of survival. We're going to talk about that in the next slide. And then they also have to have the ability to cause tissue damage. Otherwise, we wouldn't think that they were bad things. And they can do this either through direct or indirect methods. When they do this through direct methods, they produce toxins that cause breakdown of the tissues, primarily through enzymes or lysins that they secrete. And indirect tissue damage frequently is due to an ongoing inflammatory response that, rather than being protective, is now destructive. So let's take a look at some of those survival mechanisms that a bacteria may be able to use. As I noted at the end of the slide, there is a marvelous table in your text, and I encourage you to review that. And again, this isn't about memorization, but I want you to look over that. I want you to read that, because you will come away with a healthy respect, let's put it that way, for the survival ability of bacteria. So there are multiple mechanisms that they may use. They may use an exotoxin release. With an exotoxin release, they are able to damage the host cell membranes activate second messengers, or even inhibit protein synthesis within the cell itself. Staphylococcus and Streptococcus both produce an enzyme that break down cells and the intracellular matrix of the cells themselves. So that would be a good example of that. A bacteria may release an endotoxin. This is common in many of the gram-negative bacteria. Remember those polysaccharides that we talked about in the coating of the gram-negative bacteria? These polysaccharide coats are actually pyrogenic because they produce fever and the effects of inflammation. And these endotoxins are released during bacterial cell lysis or may be released from the bacterial cell membrane either during growth or when we treat with an antibiotic. Another important mechanism is rapid cell division. Remember that bunny phase. The rapid cell division is faster than the immune response to the invading organism. And cells have the ability to continue to learn, and so they may be able to increase their cell division as they adapt. Intracellular growth is a very tricky way that a bacteria survives. A bacterium can actually hide in a cell in an area that is not commonly protected by the immune system cells. This is what happens in the synovial joints. So in a synovial joint, which doesn't usually have a lot of immune cell activity, if an organism gets in that synovium, it actually has the ability to hide within those cells. The bacteria may destroy phagocytic cells by producing a toxin or by producing extracellular enzymes, and they specifically target the phagocytes. Pertussis does this. Pseudomonas aeruginosa does this. And then last but not least, the cell makeup may include a capsule or a protein coat that actually inhibits both phagocytosis or complement activation. Again, that table is just wonderful. So if we pull that all together then, in order for a bacteria to survive, it has to first resist the normal immune defenses. It has to inhibit complement, prevent the attachment of antibody, and in some way alter or neutralize the phagocytes, the neutrophils, the macrophages. It has to be able to get nutrients. Remember, it doesn't have mitochondria, so it has to have a steady supply of energy. And that it also has to be able to multiply like a bunny. So let's take a look at an example of a bacterium that exhibits a variety of these mechanisms. And that is Mycobacterium tuberculosis. This is the tubercle bacillus, and this is an acid-fast bacillus. So this isn't gram-negative or gram-positive, it is acid-fast. We actually use an acid to try that will take up the stain, a stain. So this is a very interesting organism. The tubercle bacillus survives and grows within the macrophages. It survives, and within those macrophages, it actually survives in the phagolysosome. It fuses with those lysosome granules. Now remember, the whole idea behind the lysosome was to destroy things that didn't belong there. So this bacillus, this tubercle bacillus, has the ability to fuse with those lysosome granules and survive within a phagocytic lysosome. In addition to that, the bacillus develops a capsule that also prevents phagocytosis as well as induces anergy. And this is more likely if it's chronic, but if you have enough tubercle bacilli, this can occur. When it induces anergy, which means it has the ability to suppress the host response to multiple antigens. So the tubercle bacillus comes into the body and it forms a granuloma. This granuloma then walls off and a tubercle results. When that tubercle results, it's very resistant and it has the ability to then to protect itself from the immune system. And it usually takes about 10 to 14 days for this tubercle to begin to wall off, to actually get walled off. This then leads to caseation. Caseation is when the cells within the tubercle begin to die, but that actually isolates the bacterium. And that's a good thing, but it does lead to a collagen scar. And that collagen scar continues the immune response. So the immune response, which is now being walled off within this caseated area, then becomes dormant. And as a dormant area, we know that it can then be reactivated if the environment, if the organism environment changes that allows this to then become active again. The other thing that's very interesting about this bacillus is it likes a specific part of the lungs. Remember, this is a pulmonary infection. It can disseminate, but it starts in the pulmonary system, and it starts in the upper lobes of the lungs. Now, if you remember from your normal physiology, this is an area of the lungs that doesn't get a lot of oxygen. So we don't do a lot of oxygen exchange in the upper lobes of our lungs. We do the most of that in the periphery, in our alveoli, and the bases of our lungs, especially because that's where most of the alveoli are. So when we look at a chest x-ray with someone who has TB, we're looking for these caseated areas, these collagen scars in the upper lobes of the lungs. And then it can disseminate to the joints or to the kidneys. So as a result, isn't this a poster child for how bacteria can survive? It is a contagious organism. It is an opportunistic organism. It has the ability to become resistant. So it's very, very adaptive, and it can be both latent or it can be active. What a poster child. Now, before we move on to two other examples of bacteria, we're going to talk about biofilms. Biofilms are mixed species of organisms that may include bacteria, viruses, or fungi that actually develop on non-self structures or non-self instrumentation in the body. I call this microorganism sludge, because it may be a variety of bacteria, viruses, and fungus all in this sludge. But what this biofilm, my sludge, does is that it provides a survival advantage because it protects these organisms from the immune system as well as protects the organisms in this biofilm from anti-infectives and antibiotics. Now, this is much more likely in chronic or recurrent infections like staph, E. coli, and frequently is something we're going to be concerned about in someone who is immunocompromised. So then when we think about non-self structures that we would be interested in, we think about urinary catheters. We think about invasive vascular lines. We think about an endotracheal tube that may be in the upper respiratory tract. So when we think about all of this biofilm, we go back to the idea of colonization. So we know that in most invasive lines and definitely urinary tract catheters, we are colonized within 24 hours and we have a development of a biofilm fairly early. However, how quickly the biofilm develops and what it chooses to align itself with is variable, and it will vary by not only the organisms but also the individual. So let's look at two very specific bacteria examples. And these are two examples for you to have an understanding of. We're going to look at one that is gram-positive and one that is gram-negative. Staphylococcus aureus is gram-positive. And we know that we are especially concerned with Staph aureus because of the increased risk of Staph aureus in causing healthcare-acquired infections. Now we know that Staph aureus is part of our normal flora, both on our skin and in our nasal passages. It's estimated that about 30% of the U.S. population actually have Staph aureus in our nasal passages. Staph aureus, as we talked about before, is a very large family, has numerous strains, and is incredibly adaptive. What the Staph aureus bacteria does is adhere to the surface proteins, and it goes to the connective tissue and or the epithelium. And the specific proteins that it seems to like are fibrin and fibronectin. Once it gets there, it begins to develop a protective capsule. Those protective capsules then protect it from phagocytosis and begins to mask that staph antigen from being neutralized. So this is essentially a cloak of invisibility if you're into superheroes. It also then produces proteins that inhibit complement activity. Now we know that if we inhibit complement activity, we decrease the ability of the macrophages to be chemotactic. Staph aureus is also resistant to intracellular oxidative lysis, and then it has the ability to invade tissues through a variety of toxins that it produces to destroy the tissue cell membranes, to lyse those phagocytes, to break down lipids, and also can lead to antibiotic resistance. So very adaptive and potentially very, very dangerous. So what about E. coli, Escherichia coli? Escherichia coli is a gram-negative bacterium and is a good example of how different bacteria like different environments in different parts of the body. So E. coli is part of our normal flora in the GI tract. It's part of our microbiome. And we also know that it's also part of the microbiome in many other warm-blooded animals and in their GI tracts. In the bladder, E. coli has specific adhesion molecules that bind with the glycoproteins that are actually expressed on the bladder epithelium. Now this is really important because, as I said, this is a great example of how different bacteria like different environments in different parts of the body. You don't hear a lot about E. coli pneumonia. It's very uncommon, but you hear a lot about E. coli sepsis and urinary tract infections. And we know that it can also spread to sepsis. We previously talked about urinary catheters being coated with a biofilm, and E. coli is frequently part of that urinary catheter biofilm. Also, like other bacteria, various strains develop antibiotic or anti-infective resistance. In our current armamentarium, we know that depending on where you live, E. coli may be resistant to sulfa, which is an anti-infective, or ciprofloxacin, which is an antibiotic. Let's turn our attention then to fungus infections. A fungal infection, this is called mycosis. Now this might be a new term for some of you, but I learned about this when I was in college because my college roommate in my undergrad days actually majored in medical mycosis. Very narrow bachelor's degree, but she knew a whole lot about fungus, and as a result, I ended up learning a little bit about fungus as well. So remember that a fungus is a mold, a yeast, and it is a dimorphic structure. These structures have a cytosol, and the cytosol has organelles, and as a result they do have mitochondria. The cell wall component has a polysaccharide, but these polysaccharides are different from those of bacteria. When we're looking for a fungus, we actually stain it with a KOH stain, which is a potassium hydroxide stain. One of the most important things when we think about a fungus infection is that fungus infections are incredibly opportunistic because, again, this is part of our microbiome. T cells are very important in order to limit the infection of a fungus and produce cytokines for macrophage activation, because remember those T helper cells. So if we suppress T cell function, we increase the risk of developing an opportunistic fungus infection. Like bacteria, fungus are highly adaptive to the host environment. They're very tolerant to temperature change, to pH changes, and to hypoxic environments. They also have the ability to change their morphology, or the way they look. And actually, this is something that Candida does, Candida albicans does. Candida albicans has the ability to change from that single-celled yeast structure to a filamented, hyphated form of the structure that is highly virulent. So when you think about that mold in your refrigerator, remember how it grows up from the bread or whatever else might be growing in your refrigerator right now. So not only does it have the ability to, is it very tolerant to the environment, to that temperature change, pH change, or changes in oxygen, the ability to change the way it looks from a single cell to a hyphated form. It also can survive within macrophages and can produce immunosuppressive cytokines. Like a bacterium, though, it can cause tissue damage either through direct or indirect mechanisms. Let's take a closer look then at one of the most common funguses or fungi that you will encounter, and that is Candida albicans. Once again, this is a normal part of our microbiome. It lives on the skin, in the GI tract, and in the mouth of about 55% of the population. For women, about 20% of the women have Candida albicans as part of the biome of the vaginal tract. What Candida does is it produces cell wall adhesion molecules that allows it then to adhere to cells as well as medical devices like vascular central lines, as well as urinary catheters. Candida also becomes extremely opportunistic when someone is on an antibiotic for therapy. Now remember, antibiotics are used against bacteria, because what happens when we use antibiotics, it changes the bacterial normal flora that were supposed to be there. Our microbiome has a variety and a wealth of protective bacteria, and those bacterial normal flora actually produce antifungal agents. So when we decrease that normal bacterial normal flora, we upset the balance between the antifungal agents and the normal microbiome Candida. So I call this a turf war, because what's happening is with the decrease in the bacteria, that allows then the Candida albicans to opportunistically overgrow or to grow. We know that invasive and disseminated infection is especially likely with neutropenic states like cancer, AIDS, or transplant. And this can occur because Candida can actually suppress the immune system. It does this by decreasing monocyte and macrophage function, as well as decreasing the production of C3, which is part of our complement pathway. Remember, if we change that complement pathway, that then decreases chemotaxis of our phagocytes. So, Candida, very opportunistic, especially if we disrupt the microbiome. as well as it has the ability to actually directly suppress our immune system through changing monocyte macrophage function as well as decreasing production of the complement. So we've talked about bacteria, we've talked about fungus, now let's talk about viral infections. So let's review a little bit about that overall pathophysiology of a virus. So when we think about opportunistic and adaptive organisms, think about a virus or any virus. A virus is a simple structure, and that simple structure is protected by a capsid. That capsid is a protective protein shell. And that capsid may also have protective envelope that includes that is included in the plasma membrane of the infected cell. Therefore, when a virus infects a cell, it becomes incorporated in that plasma membrane of the cell itself, and when the immune system comes by, it sees this cell as self. It doesn't see it as completely abnormal or completely antigenic. So that's an important thing that they're able to do. We classify a virus by nucleic acid in the cell structure. So is it an RNA or a DNA virus? Is it single or double-stranded? And does it use reverse transcriptase for replication? The other thing we want to remember is that this is an intracellular pathogen. So a virus replicates within the infected cell, and the life cycle of this virus is completely inside the cell. So you have an intracellular pathogen that has to be able to attach, penetrate, uncoat, replicate, reassemble, and then be released for its full life cycle. So let's take a closer look at that. So attachment. So as we walk through these phases then, the virus attaches to the host cell. And it's a protein on the virus and the receptor on the cell that's being infected. So once it attaches to the host cell, now it can penetrate the membrane. And it can do this through endocytosis or by fusion. Once it penetrates that membrane, now it is going to uncoat so it can release the viral nucleic acid inside that host cell that it is now infecting. Inside the cell now, it is able to replicate, and it replicates the viral proteins as well as messenger RNA that then assembles a new product that is called a virion or a virion. Once it does that, now it is ready to be released into the circulation as a mature virus cell to go to another cell and do additional damage. So that cell damage then can occur in a variety of ways. Direct cell lysis, facilitating programmed cell death or apoptosis. It may actually fuse with adjacent cells that are close by, or cause fusion of adjacent cells. It may transfer into a cancerous cell, like the Epstein-Barr virus. And remember, it can change the identity of an infected cell to become an antigen, and then we actually then start breaking down the tissues because now we think that cell that it infected is an antigen, so we're going to destroy it. So in order to protect from a virus, it's to protect our body from a virus, we either have to have an antibody so the virus can't get in the cell, or we have to activate cellular immunity, those T cells that can recognize the antigen changes on the surface of the cell. However, viruses, like bacteria, are very, very tricky. And they can overcome our defenses, our protective defenses that we just talked about, either by producing antibodies so it can't get in the cell, or the T cell being able to recognize the changes. But that virus can overcome through rapid multiplication. Remember, less than 4 to 5 days, so the immune system hasn't had a chance to mount the response. Through intracellular survival, remember that's a big thing with a virus, they survive inside cells by having a self-protein coating so that they look very much like an unaffected cell. So they live inside the cell and they look like me, therefore protective, as well as antigenic changes. And with an antigenic change, they actually have the ability to change the way that cell looks so that we don't recognize it as readily as an antigen. So we're going to look at 4 viruses. We're going to look at influenza, herpes, measles, and human immunodeficiency virus, or HIV. It's important that you review how these viruses are spread, because that really helps us protect ourselves from these. As you can see, many viruses are spread by droplet or aerosol transmission. So that's how we spread flu, the pandemic of 1918 that was just very, very deadly in both Europe as well as the U.S. The herpes virus and measles. See, they have some very similar ways of spreading, but influenza, you can have contaminated surface, herpes, direct contact, measles, not direct contact. HIV is different because this is a body fluid-borne virus and is not spread by aerosol and droplet. And we're going to be differentiating between HIV, infection, and AIDS. Let's start, though, talking about influenza. Influenza is actually a family of RNA viruses, and there are different types or different strains that can change from season to season, although many may duplicate over a couple of years. So that's why we have influenza, that's why we have A, B, C, avian, swine flu. Those are all families of the influenza virus that is an RNA virus. Now, the influenza virus actually has 2 surface proteins. It has, and one of those, it also has a hemagglutinin protein that binds to receptors on epithelial cells of the throat and the lung. Now, this is a really big deal because I think it helps us understand why influenza frequently and primarily focuses on the respiratory tract, because because that's the hemagglutinin protein has a special affinity on those receptors on those epithelial cells in the throat and in the lungs. Influenza virus also makes an enzyme that breaks down the cell membrane, and that allows the release of the viral particles from those infected cells. We know that the incubation period for flu is relatively short. It's only a couple of days, and the symptoms are very vague to begin with: fever, ache, fatigue. That's why we call this viral syndrome. But these are due to the release of those pro-inflammatory cytokines and the chemokines, including tumor necrosis factor and interferon. And the chemokines are actually produced by this flu virus, by the flu virus infected cells. So as we talked about before, or as I mentioned before, these strains have the ability to change. And this is what's called antigenic shift. And this can be minor or it can be major. And this is the way strains can be very different. And this is the way they interact with, and the way they interact is how they interact with the immune system. So this is the antigenic shift, and this is why we're constantly changing the type of our flu. Let's look at the herpes virus. In the herpes virus, we're looking at two large groups of virus. Both simplex and the zoster/varicella, both infections are more common in immunosuppressed individuals, and the simplex virus, we know, has the ability to activate with fatigue, fever, or stress. How often have you been really stressed out and you develop a fever blister? That's the herpes virus. So let's start first by talking about herpes simplex. Herpes simplex, there are two major strains, HSV1 and HSV2. HSV1 is usually an oral infection spread via contact with the saliva. This causes an infection of the epithelial cells, and the virus moves along an axon to a dorsal root ganglion. And then what's important is the virus sheds from the initial point of infection. So if the initial point of infection, because this is generally oral, although it can progress down into the throat, but it's going to shed from the mouth. If you have a fever blister, you're going to shed from the fever blister. HSV2 is usually a genital virus, and it also spreads or is acquired through mucous membrane contact. Once again, virus sheds from the point of infection. So through sexual intercourse would be the most likely way for HSV2 to shed and be transmitted. Now there's a second type of herpes virus, and this is the zoster and varicella, and this is the VZV as opposed to the HSV. VZV, or varicella zoster virus, is the zoster and is that family itself. So varicella is chickenpox, right? So, and this is the same virus. So varicella manifests as chickenpox, but zoster is a reactivation of this virus that was acquired earlier. And the virus appears as vesicles along a dermatome. So herpes zoster has a dermatome relationship. The lifetime risk of acquiring herpes or demonstrating herpes zoster, which is a reactivation of the varicella zoster virus, is between 32 and 50%. That's very, very high. So the virus appears as vesicles along the dermatome. But it's important to know that the virus multiplies in the lungs but becomes dormant in the nerves, which is why it becomes a latent virus that can then be activated. Now, mom can transmit this virus to the neonate, and if it risks negative CNS effects if mom does actually have the varicella virus and transmits during the pregnancy. Now, as we age, we are more likely to reactivate this varicella virus, and it activates as zoster. One of the biggest problems we have is post-herpetic neuralgia after zoster, because remember, this has a dermatome relationship, and it is very, very painful. Post-herpetic neuralgia affects about 2/3 of the patients who actually get the zoster, who actually manifest herpes zoster. In the last, I think it's 5 years, maybe 10, we do have a vaccination for zoster, and it is recommended that individuals be vaccinated after the age of 50 to 60. However, we know that as we get older, that vaccination is less effective. At the age of 50, the vaccination is about 70% effective. Between 60 and 69, it drops to 64% effective. After the age of 70, we really start seeing a drop-off. It starts dropping off to about 40% at the age of 70, and by the time we are 80, it is a very ineffective vaccination, and so only about 18 to 20% of individuals will actually benefit from the herpes zoster vaccination in preventing the zoster. However, we do know that one of the benefits of the vaccination, regardless of age, is it does help with the incidence and the severity of post-herpetic neuralgia. It does, in about 50% of individuals, regardless of age, it does decrease the length as well as severity of the post-herpetic neuralgia. The third virus we're going to talk about is measles. We just talked about herpes. So with herpes, we're going to talk about the two forms, rubella and rubeola. Rubella is what we used to call German measles. It's the 3-day measles, and this is an RNA virus that spreads through the upper respiratory tract. Now, this virus manifests as a maculopapular rash on the face, the trunk, and the extremities, and it has a fairly long incubation period of 14 to 21 days. One of the essential pieces to remember about rubella infection is if a mother has a rubella infection, has the 3-day measles during pregnancy in the first trimester, she is at very high risk for congenital rubella syndrome. Congenital rubella syndrome is a constellation of defects that occur in the infant of the mother who had rubella during the first trimester of pregnancy. Congenital rubella syndrome, the manifestations and the negative pathophysiologic effects in the fetus may include sensory neural deafness, retinopathy and or cataract development, and congenital heart disease. Many of the children may have a pulmonary artery stenosis, they may have patent ductus arteriosus, or may have valvular defects. Rubeola, also called regular measles, is an RNA paramyxoma virus. It also spreads through the upper respiratory tract. It spreads through the tract, but it actually amplifies in the local lymphatic tissue and then disseminates. It also, like rubella, it is a maculopapular rash that is on the head, the trunk, and the extremities, but it develops something called Koplik spots, and these are little white spots that are in the buccal mucosa 7 to 12 days with a 7 to 12 day incubation. Now, the negative effect of the regular measles is both rubella and rubeola can lead to a severe pneumonia and acute lung injury, and may also lead to encephalitis. Encephalitis is more likely to occur with rubeola than with rubella, but both can lead to pneumonias that can be life-threatening. So vaccination is critical for both rubella as well as rubeola. And we know that we've had a recent rubella outbreak in the U.S., and it was due to unvaccinated children. The last virus we'll talk about is HIV, the human immunodeficiency virus, and we call this an acquired immune deficiency because it's a result of an infection. So the HIV virus is a retrovirus. And the genetic information for this virus is in 2 copies of the RNA. This virus uses reverse transcriptase to convert the RNA to double-stranded DNA. Now, we know that this retrovirus may or may not be activated, and so it does have the ability to remain dormant. With this conversion of reverse transcriptase and the conversion to RNA to double-stranded DNA, integrase, which is an enzyme, facilitates the insertion of and essentially allows new DNA to enter infected cell genetic material. So this is the way the you might know about how some of our antiviral meds work. It inhibits this integrase, or it is a reverse transcriptase inhibitor. So you can see how antivirals for HIV actually work through altering the pathology, the pathophysiology of how this virus actually gains hold. If the virus is activated, the infected cell begins translation of the viral information, which then leads to lysis and death of the infected cell. Once that infected cell dies, the virus is shed into the lymphatic tissue, and that's how it then becomes disseminated. Now, primary targets of the HIV virus are the CD4 cells, the macrophages, the natural killer cells, and the CD8 cells. Remember, CD4 cells are responsible for making our T helper cells. CD8 cells are our cytotoxic T cells. So these primary targets, what actually happens is the HIV glycoprotein actually attaches to the CD4 molecule on the T helper cells and the monocytes. It then infects and depletes the T helper cells. So we have 2 types of virus. We have HIV-1 and HIV-2. HIV-2 is a much less virulent variant of this virus, and that's what we see in sub-Saharan Africa more than we do in the US and other parts of the world. HIV-1 causes indirect tissue damage by inducing cell death. That's apoptotic cell death of uninfected T cells, neurons, and monocytes on the cell surface. The other thing that the HIV-1 virus has the ability to do is develop a syncytium. The syncytium is multinuclear cells that result from multiple cell fusions of uninuclear cells. So let me say that again. A syncytium is a multinuclear cell that results from multiple cell fusions of single nuclear cells. So as a result then, what this virus has the ability to do is to develop this syncytium and has the ability to develop a mass of cells that is very damaging. Now when we look at the difference between those 2 types of virus, the HIV-1, which has the ability to do the things we just talked about, and HIV-2, which doesn't have the ability to develop syncytium and is less virulent, the difference in the viral makeup between these 2 viruses is 1 gene. So let's take a look then at what this virus does, and we'll see if we can summarize this. So the picture is a susceptible cell. The virus attaches to the CD4 receptor on the membrane of the receptive cell, and that's right there. Here's your T cell, and it's attaching. The viral genetic material then actually enters the cell, and HIV RNA, through reverse transcriptase, converts RNA to DNA. So you've got the conversion here. You've got the virion RNA. Reverse transcriptase then takes that double-stranded DNA, makes new virion RNA, and makes through integration, and then transcribes it and translates it into a new viral protein. So then it replicates, new virus sheds into this cellular matrix. So you've got all this virus shedding in here. As it sheds it, as it replicates, the new virus sheds into the matrix, and you shed then into the extracellular matrix. These are the new viruses that now they are shedding outside the T cell itself. And then it enters the lymph areas, and from there, the tissue. So then how does this virus actually go about killing things? Well, it probably kills by shedding. And when it sheds its particles, it induces apoptosis of uninfected target cells. Remember, the target cells are the T lymphocytes, the monocytes, and the monocytes. Or it may cause that intracellular fusion and syncytium formation that then leads to apoptosis. The end result of this pathology and this pathophysiology is destruction of T helper cells, decreased production of T cells in the thymus, and damage to lymphoid organs. So I think we could agree that it's a nasty actor. So as we think about this infection then, we think about what an acute HIV infection would be. Acute HIV infection is actually a syndrome that occurs after the initial infection. So this would be we're talking then about manifestations of an acute HIV infection. It occurs in about 40 to 90% of individuals who actually are infected with HIV, and occurs within 1 to 6 weeks from exposure to the virus. An acute HIV infection manifests for about 3 to 14 days. And it's very easy to miss because as you look at these manifestations, you can see that this is a flu-like syndrome. So, we also know that because of the length of time that it takes for this virus to get going, you have a window of HIV. And we actually can build antibody in 4 to 8 weeks. The window is the period between infection and antibody production. But if they are infective if they have the virus and therefore are able to transmit it. So of course this is what we're testing for. So the end result of this pathophysiology is, as we said, decreased level of T cells, decreased production of new cells in the thymus, and damage in our lymphatic organs. Because remember, CD4 cells produce helper cells. As a result then, the CD4 count helps us with diagnosis and status of the infection, and in addition to that, we use the viral load. And so we use CD4 count and viral load to determine the status of this infection in an individual. Now, viral load is important because we talk about the number of viral copies they have. And when a viral load is not detectable, it does not mean that someone who has had HIV is cured. It just means that we can't detect the virus. Therefore, we use it for treatment monitoring more so and we don't use it for diagnosis. We use HIV antibody testing for diagnosis. HIV infection is characterized by a CD4 count greater than 200 and the absence of an AIDS-defining history or having had one in the past. AIDS, however, is the presence or history of an AIDS-defining illness and or a CD4 count less than 200. If an individual has a measured CD4 count less than 200 even once, they are diagnosed with AIDS. So once again, as we think about infection versus AIDS, when we look at infection, we're looking for signs of immunocompromise. So you look for the presence of thrush, candida, in the mouth. Cervical dysplasia in a female. Dysplastic cells, remember, are abnormal cells. Cervical cancer in situ, abnormal cells. Remember that in situ idea. Do they have a temperature of 38.5 for more than a month? Do they manifest oral hairy leukoplakia, which is a very characteristic sign of an oral sign? Do they have herpes zoster? Herpes zoster is is more common in individuals with HIV infection than it is in the general population. Do they develop idiopathic thrombocytic purpura, pelvic inflammatory disease? Do they manifest peripheral neuropathy? Vaginal yeast infections that are persistent, frequent, poorly responsive. All of these things tell us that an individual with HIV infection is immunocompromised. And so what we want to pay attention to is when an individual is immunocompromised, they are much more likely to develop an opportunistic infection from something in the environment. However, they do not carry, an individual with an HIV infection does not have the diagnosis of AIDS until, as we talked about, their CD4 count drops below 200 and or they develop an AIDS-defining illness. And I include these for your information, but it's important to be sure that you understand the difference between the signs of immunocompromise and an AIDS-defining illness. So if someone came up with any of these things on the list, pneumocystis jirovecii pneumonia, toxoplasmosis, which is a parasite infection, disseminated Mycobacterium avium, Kaposi sarcoma, tuberculosis, esophageal or tracheal candida. So it's not just thrush or a vaginal yeast infection. We're looking for it in the esophagus or in the trachea. Do they have CMV, histoplasmosis? Did that cervical cancer in situ or cervical dysplasia, is it now invasive? Or do they have recurrent bacterial infections? So we've talked a whole lot about different kinds of things. We've talked about bacteria. We've talked about fungus. We talk about viruses. Currently in our prevention techniques, we can develop vaccinations against viruses, but we don't have vaccinations against and bacteria, but we don't have any against fungus. And I wanted to clarify these two terms because we frequently use them interchangeably. This is just to increase our specificity in our conversation, because I even find myself using them interchangeably, and I know I shouldn't. Vaccination is the injection of a killed or weakened organism that produces immunity. So vaccination involves injection of an infective organism in order to produce immunity. And a weakened organism is also called an attenuated organism. Immunization is the process. So injection is the act. Immunization is the process by which an individual actually becomes protected from a disease. And this can occur through vaccination or for some diseases, recovery from the disease itself. And this would be what kind of immunity? active immunity. Remember, for active immunity to occur, the organism had to participate in the development of antibody. And that's what happens as a result of this immunization process. It's the protection from the disease. The last thing we'll talk about in the pathophysiologies of infections is the concept of antibiotic resistance. And I include it here because I think it flows well, and I think it's important, since we talked about how tricky bacteria is, and even a virus is, how those organisms can become resistant to anti-infectives and antibiotics. So antibiotic resistance is the ability of an organism to adapt genetically to an antibiotic. And there are a variety of mechanisms by which the organism can actually develop resistance. And again, tricky, tricky, tricky. So an organism can actually inactivate the antibiotic. So this is what happens with a beta-lactam resistance, because it actually develops, it inactivates the antibiotic through beta-lactamase. We've also seen this happen with a new superbug, which is carbapenem-resistant enterobacteria. CRE, which is carbapenem-resistant enterobacteria, has a plasmid, or a mobile piece of DNA, that has an enzyme that breaks down antibiotics. In addition, it has the ability to transfer this plasmid, and therefore the antibiotic resistance, to normal flora bacteria. In addition to inactivating the antibiotic through these enzymes, the organism can actually modify the target molecule. This is what happens with an AZT-resistant reverse transcriptase. It can change metabolic pathways to be less sensitive to the antibiotic, or less resistant to the antibiotic itself, by changing its own metabolic pathway. This is how organisms, bacteria, become resistant to sulfonamides and E. coli. The organism can actually develop multi-drug transporters that prevent the entrance of, or the increase the efflux of the antibiotic. So it can either prevent the antibiotic from getting in, or move the antibiotic outside the cell faster, so it's less protected. So this is how Mycobacterium tuberculosis is protected from aminoglycosides. It actually basically shoves the antibiotic out of the cell fast. So how do we decrease antibiotic resistance? You probably, at your workplace, you may have gone through some strategies. One way that is proposed is to decrease the use of antibiotics in our food sources. And we've made a lot of strides about that in the U.S. We can do this through antibiotic stewardship. One of the biggest things we do in antibiotic stewardship is we narrow the spectrum of our antibiotics. Once we know what the organism is, we go from a broad spectrum to a narrow spectrum antibiotic. We also know that we need, part of our antibiotic stewardship is being very careful about using antibiotics in our outpatient care. This is the just say no strategy. As a healthcare provider, you will be asked for antibiotics when someone has a virus. You have to say no, because we know that antibiotics don't work against a virus. We need to decrease the incidence of central line and catheter-related infections in the hospital environment. So get them out when you can, and use them for the shortest amount of time you possibly can. And then last but not least, good, solid infection control methods are personal, as well as both in our personal hygiene as well as our environmental hygiene. And certainly staying healthy ourselves helps us. We want to keep our own microbiome healthy. So in summary, microorganisms have common steps as they become pathogenic. We talked about these steps. Many organisms are normal flora, but they can become pathogenic when the protection of the immune system has been compromised. We talked about that a lot. Infectious organisms are tricky, and their ability to adapt is incredibly strong. You have to admire their abilities. But we're strong and tricky too, and we have methods to decrease the ability of organisms to adapt to these therapies. I hope this information has been helpful and you've learned a little bit more about infections. Let me know if you have questions.